Welcome, everyone. Good morning, good afternoon, good morning, especially those in the West Coast. Welcome to the webinar sponsored by Global Healthy Living Foundation. My name is Dr. Robert Popovian. I'm the Chief Science Policy Officer at GHLF, as well as Health Policy Fellow at the Progressive Policy Institute and the Visiting Policy Fellow at the Pioneer Institute. Our webinar is entitled, Big or Small, Red or Blue, States with Laws Protecting Patient Assistance Programs have not seen health insurance hikes. This is very important, health insurance premium hikes. This is a very important topic. It's a topic that a lot of folks have worked on, both on the state and the federal level, trying to protect patient assistance programs. So today, we have a great team from Global Healthy Living Foundation who's going to be discussing our free tool that is available to everyone. I'm going to start off with introducing my dear colleague, Ann Sydor, Dr. Ann Sydor, Director of Research, Development, and Communication. Esteban Rivera, a fellow economist, a data scientist for Global Healthy Living Foundation. But last but not least, and we're going to go with her first, is JP Summers, our patient advocate, community outreach manager. The reason being is that JP not only works with patients on behalf of GHLF, but she's actually a patient and has experienced the issue that we're going to discuss today, which is the accumulators, impact of accumulators and maximizers on patients. So before we get started, some housekeeping notes. We are recording this webinar, so it will be available to anyone post completion. We're going to put it in various platforms for everybody to access. Second, we're going to have a Q&A session. We want to answer all of your questions. So please use the Q&A tool in the bottom part to be able to, ask any questions, and we're going to go through them at the end, and we're going to address as many as we can, depending on the time constraints that we have on this webinar. Look, this is a very important issue. This is an important issue because patient assistance programs have been developed to help patients to be able to afford their medicines. And for the last 5, 6, 7, 8 years, insurance companies and the PBMs, the pharmacy benefit management companies, have instituted tools or schemes really to steal these patient assistance programs from patients. And Global Healthy Living Foundation has been involved in this for the last couple of years. We started in 2022. We launched a tool we're going to talk about. We've updated it now in 2023 with new data. But the good news is 19 states have passed this legislation. There's federal discussion on the federal level about passing a federal law, and we'll discuss why that's important as well. But there's progress being made, but more progress is needed to protect patients. And it's good that 19 states have passed. We have large states like Texas and New York that have passed this legislation. And so it's important for us to do this for everyone. We're going to have polls throughout the discussion. So we're going to first and foremost, we're going to put out the poll with regards to the first one. So can you queue up the poll, please? So the question is, do you know if your insurance policy has an accumulator or a maximizer? That's the first question. All right. Well, it's about a third. Not surprised. We're going to end the poll here. I am not surprised at all, to be honest with you. And the reason I'm not surprised is because we are seeing the same thing. When we talk to patients, what happens is that they tell us, and employers even, that they don't even know if this program has been instituted in their policies. That's because a lot of people are not telling when they're selling the insurance policy to the employers. So this is not surprising to us. So please keep that in mind. So if you don't know, if you know, that's great. If you don't know, that's not unusual. So without further ado, we're going to get started. As I always say, we put the patient first at GHLF and everywhere I work and whoever I collaborate with. And we're going to bring in JP first. She's going to talk about her own personal experience of how accumulators and maximizers have impacted her and her family's life. So JP, take it away. Thank you for being here, and thank you for supporting us in this program.
Thank you, Robert, for the introduction. So in my role, I have the opportunity to guide people like me who live with one or more chronic illnesses to educational resources and opportunities to participate in advocacy and research. And For me, I live with several chronic illnesses. Chronic migraine has been the one that has significantly impacted me, but I also live with rheumatoid arthritis and heart failure. With migraine, my attacks can be so much more than excruciating head pain. It's decreased motor skills, sensitivity to light, sounds, and odors, severe nausea. The one that really took a toll on me was decreased motor skills and also issues with balance. My neurologist suspended my driving privileges for 2 years because of those symptoms. And when we came across a medication that finally helped me to function better, I was excited and I thought this is something that's really going to help me to get a better quality of life. And it did. But that excitement was very short lived when I went to my pharmacy and realized the medication that um, I had, did not have to pay very much for, all of a sudden tripled in amount. And that's when I discovered that it fell into the accumulator program. And that was a point where I never thought I'd have to make a decision about whether I could afford my medication, because also around that time, my son, who was also diagnosed with chronic migraine, had a medication that fell into the same criteria. So here I was left with a decision to pick his health over mine, and no one should ever be put in a position to not take their own medication to afford a loved one's treatment instead. But there I was, stuck in a situation where I never thought I'd face and had to. And when I went through that, I learned so much more about the situation, and I was just surprised that I had to go through that, and other patients were experiencing it as well. And because of that accumulator program, that was something that particular medication, I had to figure out, how was I going to get access to it? How was I going to be able to afford it? It wasn't just me; it was my family that was going through it as well. And it's a financial burden, also mentally and emotionally. It does take a toll on you as a patient.
JP, thank you so much. I mean, that's it, right? It impacts you, it impacts your family, and you should never be forced to choose your health over a loved one's health or vice versa. And people should be able to take the medicines that helps them to manage their chronic diseases, because that's why it's important. If a medicine is not taken, then it's not effective. So I want to remind everyone, please leave your Q&As in the Q&A box. If you see the tab in the bottom, you can click that and put your question in there, and we will get to those questions at the end. We're very eager to answer everyone's inquiries. I also encourage you, and Anne will do a better job than I will, to go to the website and learn for yourself. We have a lot of information in there. People can explore that website. But without further ado, I'm going to bring Anne in. Anne has been a dear colleague for the last couple of years. We've been working together. We've published a couple of papers, really, just putting it out there. But Anne, my pet peeve has always been, where does the data come from? I don't like when organizations put out reports or websites and the data is something like data on file. And so Anne's going to show us the website. She's going to show us the graphics that we've designed. But more importantly, she's going to also talk about, how do we come up with this information? And the goal, just remember, always is that anyone can go and find this data. This is not proprietary information for GHLF. So Anne, take it away.
Thank you so much for the introduction, Robert. The data for this analysis comes from the Healthcare Information Exchange database, which is a repository of all premiums for the ACA plan and can be used really as a proxy for how insurance premiums have changed from year to year. So this is a publicly available database, as Robert said. Anyone can go and look at this data. It is a large amount. There are dozens and dozens of insurance programs from state to state. What we've done is we've taken the average premium for each of the metal tiers. So there are different levels of insurance: bronze, silver, gold. We've taken the average for each of those tiers for each state in a given year. And we looked at how states compare from one to the next. We've also looked at how states with bans on accumulators compared to states without bans on accumulators. And here I'll just switch over to sharing my screen and show you the actual website. So when we look at this website, again, this information all comes from the Healthcare Information Exchange. We also have terms defined. A lot of people aren't sure whether or not they have an accumulator or a maximizer in their health insurance policy. Accumulators and maximizers affect patient assistance programs. If a patient has a $1,000 deductible and they get $500 in the form of coupons or copay assistance or any other assistance to afford expensive specialty brand name medications, that $500 that they pay with a coupon used to go towards their deductible. With an accumulator or a maximizer policy, that no longer happens. They pay the $500 from the assistance program, but instead of having $500 left in their deductible, they still have $1,000 to pay. That's why the cost of JP and her son's medications went up. That's why they couldn't afford those medications, because the assistance had gone to the insurance company and the pharmacy benefit manager instead of to the patient. So laws have been, advocated for and passed in 19 states. You can see those in blue on the website. States that have not passed legislation protecting patient assistance programs are in orange. Then when we come down and we look at this graph, what we see is average premiums for all states with bans on accumulators and maximizers in blue versus all states without bans on accumulators and maximizers in orange. And what you see that's really important is the shape of these lines. The blue states might be a little bit higher, the orange states might be a little bit lower, but the rate of change, the rate at which insurance premiums go up or down is the same in both blue and orange states. So really, there has been no effect of these laws on the rate of increase of health insurance costs, which has been the main argument made against these laws by pharmacy benefit managers and insurance companies. And again, please put your questions into the chat. We'll come back and demonstrate the tool in just a moment. But at first, I think we're going to have our statistician and economist colleague talk about why we know these two lines really are not different.
Thank you so much, Anna. I appreciate the introduction. And I just have to reiterate that the important thing here is that when you're looking at the chart using the tool, that you're paying attention to the rates of change and those increases in the years between 2014 and 2018. That's important to consider because the first state to enact legislation was actually in 2021. In other words, there was already an upward trend in prices before legislation was passed. So any argument that assesses impact of this legislation on prices must take that into consideration. Statistically speaking, that can be done with what is called a repeated measures ANOVA test. And in layman's terms, that is a test that allows us to assess a cause and effect relationship with something such as premium prices over time and implemented legislation. So the question here is, did enacting legislation cause a statistically significant increase in premium prices when comparing that to potential increases to previous prices? I'll explain why the answer is no to that question using an example. When analyzing prices in 2022 in a specific state that passed legislation in 2021, one needs to take into consideration what previous prices were in that state and how it compares to the overall averages. No matter the selection of the state in this example, the ANOVA test shows and proves that there is no significant statistical relationship between the passing of legislation on an increase in premium pricing. One way I like to think about that is that this year's price is dependent on all the previous year's prices. So averages were already increasing over time, and that is the key factor to pay attention to here. And now Anne is going to demonstrate this in a visually friendly way.
I will once again share my screen. this is the tool that we have created that allows you to look at the data for yourself. You can see the blue line for all states that have passed laws banning accumulators and maximizers. You can see the orange line for all states that have not passed laws banning accumulators and maximizers. And again, we see that the rate of change in insurance premiums from 2014 through 2022 is not appreciably different between those two groups. You also can see how your state compares. So you can select the metal tier, and whether you're looking at purchases by individuals or small groups, but you also have the option to select specific states, looking at all states that passed, all states that didn't pass, and a state like Iowa, for example, where I know we have a viewer from. And then the line for Iowa appears, and we see that Iowa did have a higher insurance premiums than average during 2017 to 2021, but those come back down to average. Again, the key is that the shape of the line is not different from the shape of the line for the blue states. We can also look at Florida, for example. And Florida we see is very close to the averages for other states without and with bans on accumulators and maximizers. The shape of the line, again, is completely consistent. But let's look at some blue states, some states that have actually passed bans on accumulators and maximizers. New York is a good example, because in New York, the rates of insurance premiums are incredibly high, but the shape of the line increases from 2015 through 2019, a small decrease in 2020, and then these increases through 2023 match the same shape of the line here. Another state to look at that has passed bans on accumulators would be Arizona. Arizona has lower rates than the average, but the shape of the line is the same. So we hope that this makes the argument very clear that bans on accumulators and maximizers have not caused insurance premiums to rise. We welcome all of your questions. Please put them in the Q&A, and we hope that this tool and this analysis proves useful to all of you.
Thank you, Anne. Thank you, Esteban. Terrific presentation. And I have to say, it meets the three pillars of what good data looks like. Number one, it's transparent. You know where the data came from. It's publicly available. Anybody can go get it. Number two, statistical analysis was done for before and after analysis, like Esteban explained, but also was done based on time series analysis, which is super important because it's multi-year data. You can't just look at before and after, right? You have to look at the trend lines. So be certain that when insurers and PBMs raise the issue of, this is causing increase in premiums, it's absolutely false, without a doubt. There is no information to support their claim. And we have 2 years of data that we've collected, 2 years of analysis that we've done and it's posted. And this year, with additional states passing, again, the truth is it doesn't impact premiums. So what are we doing in the state level? Obviously, JP can talk about it because she's been involved both in several states. Specifically, I can remember Wisconsin and Texas that she went and testified and spoke about this passage of this legislation. Good thing for her, she lives in Texas. I can say that. She's protected. Texas passed this last year, the law that protects her. In fact, our CEO, I'm going to put this out there because he doesn't know I'm going to talk about him, but our CEO, Lou Tharp, he was calling me and saying, how come this year my patient assistance is actually going towards my deductible? I said, Lou, you live in the state of New York. You have a fully insured New York state insurance plan, and therefore you're protected as a patient. So these laws actually work. They protect patients. And I'm going to talk about what we're going to do in the future. Anne doesn't know about this, so I'm going to drop it on her. We're going to do specific case studies of patients, and starting with the GHLF family, and look at how they're being impacted by protecting in states that they live and they're protected by these accumulators and maximizer bonds. So we're going to answer all your questions, but before then, I want to encourage everyone, first of all, not only to put the questions in the Q&A box, we have already several that we're going to get to, but also remember, we need to lobby and lobby and lobby. We have to go to the other, states that have not passed this legislation. We need to go on the federal level. I know there's a active legislation on the federal level, all co-pay protection act or something to that effect, that's trying to do this. And that's super important. Why is this? Because when we talk about the state legislation, they protect patients under state insurance plans and not necessarily on self-insured or ERISA plans. So if you want everybody to be protected, not only we need to pass this legislation in every state, but we have to also pass it on the federal level to protect those patients that are not necessarily governed under state insurance laws. So that's why it's important to have both. But we're on our way. We're coming. I mean, this just started about a few years ago, and more patients are being educated, more and more providers are being educated. And believe me, this is a bipartisan issue. We have a state like New York and a state like Texas, which politically are polar opposites, but they both found a way to protect patients. So next to come is the other two large states, Florida and California. Let's see what they do, right, to protect patients. But without further ado, we're going to get into a Q&A. I'm going to try to answer some of them myself, but I'm going to call on my colleagues to answer some of them that are more relevant to them, and I'm going to call them out. So, JP, this is for you because you've done this. One of the questions is, we live in a state that doesn't have the patient protection, assistance protection. What can we do to make sure that such measures get passed in the state? What should we do? Education is first and foremost, but please tell us what your opinion is on this.
So advocacy is so important, whether you're doing it for yourself or a loved one. Speaking up, talk to your legislature, email, call, get involved with the 50 state network, because that's where we hit the ground running. I got to testify, share my story in front of, lawmakers at the Capitol in Wisconsin and Texas. And it's so important to be vocal. Even if you think your story isn't that important, it is. Every story is important because everyone is affected in some way. And again, it wasn't just me as a patient or my son as a patient, it was us as a family. We were all affected, every single one of my family members. So again, just speaking up, making that effort goes a long way. And again, it's something that you just have to be persistent about. You have to just keep voicing your opinion, keep sharing your story, because again, Texas, I honestly saw it firsthand. I was there, I testified, I was with the coalition, and to have GHLF, be there on the ground, and we worked really hard, and to have, again, sharing my story. And I know, again, it may not seem like you're making a huge impact, but every story makes an impact, every story. So the more people that speak up, the more powerful we can be, and these changes can happen. And it happened in Texas.
Thank you, JP. So our next question is about drugs, and I'm going to come to you. What drugs are being affected by accumulator program? Are they all drugs? Are they no drugs? What's being accumulator programs and maximizer programs to that affect what kind of drugs?
The drugs that are affected by accumulators and maximizers are the most expensive drugs and the specialty drugs. New drugs that have a true impact on making patients' lives better in the here and now tend to be the most expensive drugs. They tend to be difficult for patients to afford, and not just for people of low socioeconomic status. These drugs can be thousands of dollars a month, and they can really affect a family's pocketbook. So the specialty brand name drugs, those are the ones where pharmaceutical companies have patient assistance programs. There are other organizations that also have patient assistance programs, but anything that helps a patient pay for those drugs is subject to the accumulators and maximizers. So it really is the drugs that are most difficult for people to access but also most important for them to access. Multiple sclerosis treatments come to mind, rheumatoid arthritis treatments, the new biological treatments, anything that's got that brand name to it that has the higher price tag is really what is being impacted by patient assistance programs.
Just to what Anne said, that was great. Just to be holistic about it, it impacts everything. I always explain to people this way. Patients don't have two wallets, one for drugs, one for other healthcare services or their groceries, or another wallet for their rent. So we all pay for our everything through one budget. And therefore, if we're overpaying unnecessarily because our patient assistance program is being stolen by the PBM, then our ability to pay for other healthcare services or groceries or rent also gets diminished. So as an economist, Esteban, you can attest to that, you have to look at it as a global payment because we just don't have separate wallets. And that's the thing that people misunderstand about this accumulator issue, because they say, well, it just affects the health drug spending. Well, yeah, if I'm overspending on drugs, guess what? I'm probably not spending on other things. So this is why it impacts patients just beyond the chronic drug. They are driven through the chronic brand name medicines, but it impacts patients much more holistically.
And just to add to that, Robert, as a patient, not as a researcher, but as a patient, I wait for my son to get his annual echocardiogram until we've met our deductible. So he gets his annual echo in December because it's expensive, because I have to get the deductible met before I can go and have that test for him, which is essential to his well-being. If I don't meet my deductible because the patient assistance program didn't count towards it, my son isn't getting his echo that year. So it really does affect more than individual drugs. And as JP has said multiple times, it affects more than one individual in the family. It affects the entire family, all of our economics, all of that one family wallet.
Thank you, Anne. So the next question is, what is the maximum amount that can be accumulated in an accumulator? It's infinity, right? Because with accumulators especially, maximizers is a little bit different, but with accumulators, there is no upper limit. They will accumulate as much as there is. They will siphon off as much as there is in the patient assistance program. So there is no upper limit with regards to how much can they profit, the PBMs and insurers, from these programs. Maximizer is a little bit different because it maximizes the amount that is on the patient assistance program card, for lack of a better word. But in the accumulators, it's infinity at this point. With maximizer, it's a little bit different. It's maximum amount that, so that's the answer for that one. And I'm going to come back to you. How do accumulators work? Can you just give a brief description again? I know you covered it earlier.
Sure, I'm happy to do that because it's a confusing issue. Most of us don't know if these if these are in our healthcare policies. I'll quickly answer another question, which is how do I know? And the only way you can know is to educate yourself and ask the person who bought the health insurance policy or the person who sold it to you, is there an accumulator or maximizer clause in this policy? So it's really important to educate ourselves. What an accumulator, to understand how accumulators and maximizers work, we need to understand the portion of healthcare costs that patients pay. Patients are responsible for the copay. They can also be responsible for coinsurance. They may have to pay a deductible. And a deductible works like a deductible for any insurance. You pay 100% of that amount before insurance starts paying for anything. Now, with health insurance, there's one exception, which is that some preventive care is covered before you've met your deductible. But anything other than preventive care, you have to meet your deductible before insurance starts to pay any portion of the bill. Once insurance does pay part of the bill, you still have a copay or a coinsurance that is the patient's share of the bill. It's not until we reach our out-of-pocket maximum, which for most families can reach to $6,000, $10,000, That's when insurance starts to cover 100% of your costs. So after you've had a significant outlay, you've met your maximum out-of-pocket costs. Accumulators can work such that any assistance you're given does not count toward that out-of-pocket cost. So even if someone gives you $5,000 of the $10,000 you have to spend, your insurance still isn't going to start covering your costs until you've spent $10,000. Effectively, that means it's the insurance company or the pharmacy benefit manager getting that $5,000 of assistance because the patient and family are still paying the $10,000 pocket maximum. Hopefully that clarifies things. I know it's a difficult issue. Visit the website, look at our definitions. That should be very helpful.
Thank you. That's exactly what I was going to say. Go to the website. We have the definitions. We've tried to bring it down to a patient level to understand all of these things. So the next question is about New York. Actually, it's a good comment. It says New York accumulator ban just took effect on July 1st. Yes, that's true. But remember, benefit plans start January 1st to December. So they have to have implemented the change within that benefit design starting on January 1st. And most insurers have to do that because that's how they sell insurance. Next question. I think, you know, JP and Ann sort of answered this. How can we find out if my insurance has an accumulator or maximizer? It's a act of God almost to a certain extent because they're hidden in these thick documents with regards to benefit design, and it's really difficult for people to see it. And it takes endurance, frankly, to be able to get it. The other unfortunate part is that the people you trust most, which are the brokers, at times are either ignorant about the issue and they don't know about it, or they're in bed with the PBMs and the insurers and they're unwilling to share that information with you. So you really need to go do the digging on your own and ask the tough questions, but sometimes you need to educate your broker that is talking to you because they have no idea what they sold you a lot of time. The lack of information in this marketplace is just astounding. And the lack of transparency is even worse. And that's why we've decided to do what we did by being extremely transparent of how we did the analysis and how we got to the point of basically saying there is no impact on health insurance. The next question. How are insurers or PBMs adjusting not receiving the additional money? Obviously, this is prime benefit, right? This is profitability for them. And how are they adjusting it? Look, as we all know, this is a whack-a-mole issue. We're going to resolve the accumulator maximizer perhaps on the state level and on the federal level, and they'll find another scheme to be able to siphon money from patients and from employers and from the federal government. So it's just another thing that we need to do to be able to get to a point that we plug all the holes that they can fall through. But I am 100% certain at this point in the states like Texas and New York and other states that have passed these bans, their marketing, their public affairs, their teams are sitting around the PBM and insurers of how they're going to basically adjust for the loss of revenue that's going to be coming to them. So we just need to be persistent. And as advocacy organizations, as for both patients and providers and employers, that we need to make sure those things don't happen. Next question. So the good news is, and you know, government insurance, right? The Federal Employee Health Program has been approached several times by organizations, internal and external to the government, to implement accumulators and maximizers. And what they have said in writing, and these are scams, and we will not do this for a federal employee program. So we have that information. If you're interested, I can give it to our colleagues to put on the notes for the webinar. But there's actually a letter for the federal health employee insurance plans that says that we're not going to do this for the federal employees because it's a scam and patients are going to be hurt. We will not be give up. So absolutely, we want you to fight for Florida because that's another large state that needs to protect patients. And you know my pet peeve, I'm going to come to you with this question. You know, I get frustrated too because these are not coupons, these are not copay assistance programs. tell us what these are. Basically, explain to them how this helps a lot of variety of different things that patient is exposed to.
Okay. So there are many different ways that patient assistance is delivered to patients, and it really depends on the organization that's delivering the assistance, and it really depends on whether they're making it so that a patient with insurance pays $0, doesn't have to pay their copay, or whether a patient with lower economic means doesn't have to pay anything. And the truth is, no matter what we call it, whether we call it coupons or copay cards or patient assistance programs, whether it's a subsidy, whatever it is, it's a mechanism for an organization, whether it's a pharmaceutical company or a charitable organization, it's a mechanism for them to cover the costs that the patient would pay, the share of the drug cost, the share of the prescription that would be borne by the patient and family. So we really like to talk about them as patient assistance programs on the whole, and we like to talk about protecting patient assistance rather than just focusing on banning accumulators and maximizers. And that's really because at GHLF, the Global Healthy Living Foundation, we are patient-centered, patient-centric. We always put the patients first. Our economic policy is, all of our analysis is from the viewpoint of a patient. So I wouldn't get caught up in the names too much, I guess is my answer to that. The key is to focus on, are we helping the patient?
But Anne gets that dissertation from me. It's a pet peeve of mine. I don't like it being called coupons, copay cards, because they help apply to a lot of different things. And she hears that daily from me when we talk about this issue. So same with the frustration. So I want to come back to you, answer the next question, which is distinguish between self-pay insurance, commercial insurance, ERISA plans, and Medicare, and describe where advocacy should be conducted state and federal level. So on the state level, when you pass laws, it's state-regulated health insurance plans. So this is like full insurance plans, self-pay insurance that individual goes full insured, individual gets their insurance, or small employers that basically purchase plan through, which is full coverage through the state. And those state insurance plans are regulated by the state. So state law passes, it regulates them. Regarding ERISA plans, this is self-funded employers or national organizations like Home Depot, for example, that are self-insured. These are called ERISA plans. They're protected. They bypass state law, although there's the whole law that Supreme Court decision with regards to can states regulate federal government. It was the PBM issue versus pharmacists in the state of Arkansas, I believe. And the Supreme Court unanimously said, yes, state of Arkansas can somewhat regulate what is going on, even if it's a federal employee program. So in other words, that ERISA plans, federal law has to pass by and large to be able to regulate that. Medicare, obviously it's a federal government issue, and that again has to be a federal law that passes. Medicaid, it depends. If depends on the Medicaid program, but Medicaid patients are not really impacted by these things because they have very little out-of-pocket costs, if any, in most of the Medicaid programs. But Medicare, definitely, patients do get exposed to significant amount of out-of-pocket costs. So we need both federal and state to be able to do
Robert,
that.
I want to jump in and answer the second half of that question, which is where should we advocate, right? Because there are plans that are regulated at the state level, and those are individual purchases and small group purchases, but there are plans that are regulated at the federal level by the large employers, car manufacturers, self-funded insurance purchases by large corporations, all fall under the federal regulations. And that is actually the majority of people with health insurance in the US. So we believe that it is as important to advocate at the federal level as it is to advocate at the state level. But as states pass these laws more and more, it becomes easier to pass these laws at the federal level. So if you're in a state that doesn't have a ban on accumulators and maximizers, we want you to join with us to advocate for those laws in that state. And if you are in a state that has a ban on accumulators and maximizers. We want you to support the federal legislation that would protect everyone with the same benefits that you are receiving through these laws.
Thank you, Anne. Thank you for clarifying that even further. That's great. So the last question, actually we have 3 more questions. The next question is, why do patient assistance program not include patients on Medicare? The reason being there's a ban that's been placed by the federal government that patient assistance programs from manufacturers cannot be utilized. But there are other ways Medicare patients can get patient assistance, and through foundations that have been set up. That they can go to those foundations and get patient assistance when they need to. So it's just a different model. But it's not direct manufacturer support, that's for sure. That's banned by the federal government. And it's not only banned for the Medicare patients, but for Medicaid patients, any federal government employees, so VA, DOD, things like that. JP, there's a call out for you. Thank you for testifying in Wisconsin. What happened, JP? What's going on in Wisconsin? Do we still have, I think the law is still going on, right? Well, yeah, I mean, she did a terrific job in Wisconsin, and I know that the Wisconsin law did not pass, but you know, they're going to be added again next year. So a couple of more questions. Why is, oh, this is a good one. Why can someone tell me why Chamber of Commerce are in favor of accumulators and maximizers? Well, that's a simple answer. I think they are pretty much in the pocket of PBMs and insurers, especially state insurance plans like the Blues are huge supporters of chambers of commerce. And that's why. Let's be honest about it. It has nothing to do with whether or not this is going to help patients or hurt patients. This has to do more about their bottom line and how they get their funding. So that's why. And also there's misinformation. Frankly, I think that they're not been educated. They don't understand the issue. And when you go talk to employers and you try to talk to them and say, hey, this is going to impact your employees, a lot of times they back off. And I would highly suggest, and again, we're going to share this letter from the federal employee insurance plans that specifically talks about this issue, how it's a scam and they're not going to do it for federal employers. So if it's something that the federal government feels it's not a good thing for federal employers, then why is it that everybody else is doing this to their employers, basically?
Robert, I'm sorry, I was having
That's
some
okay.
technical difficulties. Yes, so back to the Wisconsin.
Go ahead.
So because I'm a dual resident, I got to actually go to do a press conference and share my story about how copay accumulator practices affected myself, my son, and our entire family. And then also I've been very actively involved with just doing just different written testimonials. I've been sharing my story with different media outlets. So again, it's so important to voice, you know, again, what's happening. And as much as I hated what I had to go through, it's what drives me to be a better advocate and to share my experiences with other patients who get involved with advocacy, just to let them know, you know what, you're not going through this alone. There's so many people that are going through it. And so again, Texas was just such a huge success, just to see that happening, that it passed. But again, Wisconsin's one right now that's in the middle of, you know, hopefully we're going to be in the same situation here, hopefully soon. So again, just being involved has been such a huge thing for me as a patient and also a caregiver. But again, advocacy is something that if you feel, or even if you're not wanting to be vocal, send an email, call. It's important.
Thank you, JP. I need to unmute myself. Now, the next question is also, are there any legislative proposals in existence that they may limit the role of PBMs or provide greater oversight? Tons of them, both on the federal and on the state level. I mean, there isn't a day that some committee of jurisdiction on the federal level is marking up a bill to regulate PBMs. And some of those bills actually have the language to ban accumulators and maximizers. Same on the state level, we've seen it. You know, whether you're talking about Senate Finance Committee, whether you're talking about the Health Committee, you know, on the House side, the Ways and Means just came out with their markup yesterday. So there's a lot of activity. I encourage you to engage both on the state level, but also on the federal level. That's important for federal legislators to hear from you, especially if you represent a group within the state that you're a constituent of theirs. Again, I think there's a lot of activity. How it's going to end up, it's going to be very interesting. But again, you need to advocate, you need to get out there, and we need to recruit more patients like JP. So if you're a patient actually who has experienced this, please come to Global Healthy Living Foundation. Please tell us your story. We want to know you. We want to get to know what happened to you, because if you don't put a face in front of these policies, unfortunately, policymakers just have a tendency to not pay attention. So it's always important to have a face with what happens.
Right. I would also encourage,
Go ahead.
excuse me, I would also encourage everyone to sign up for updates from GHLF and from the 50 state network. We do publish articles on these laws frequently, both at the state and federal level. So if you want to stay informed about these laws and what's going on with them, please do join our mailing list.
Yes, please, and visit the website. So I'm going to end. There's one last question, the PBM evolution. PBM evolution has, when I was in grad school, I had an opportunity to work with one of the earliest PBMs in the United States in the 1990s, when it was developing, and it was developing the whole rebate contracting model and things like that. PBMs are not going to go anywhere. They're a necessary part of the healthcare system ecosystem with regards to processing prescriptions. That's what they did. That's how they started. That's what they need to continue doing, because they're a vital portion of, when you show up to a pharmacy, the pharmacist gets paid, your copay amount, blah, blah, blah. They're not going away. What has happened over time, though, that's not a lucrative business model for them. That's like putting all of your money in your savings account and not investing. What they're doing now with contracting, through rebate contracting, through the fees that they're charging, through specialty pharmacy ownership, which is going under the radar, those are the things that they're really bringing the money to help their bottom line. And this accumulator maximizer schemes that they've perpetrated, whether it's spread pricing with generics, that's where they're making money, and that's where we need to start regulating them. So no, should the PBMs go away? No. Should they go back to what they were doing initially? Yes. Are there problems, misaligned incentives that has created? Are drug pricing increasing significantly, or spending significantly because of the PBM practices? Absolutely. And if you don't believe me, go to JAMA. JAMA published an article, which one of the co-authors is actually an executive within AHIP, which is the trade organization that represents insurers. And in this article, they looked at the 4 insulins in the United States. And what they showed is that even though gross spending for those insulins increased over time, net spending after all the rebates, fees, 340B program, everything else was dropping. So who's capturing that margin? That's the PBM. And that study was published. You can go see it. We can also put it on the webinar notes for you to take a look at it. There's no doubt there's a need for PBMs, but what we have today is not what they were intended to do. And we need to roll this back. Keep an eye on a lot of the federal and state legislation that's coming. That's right. Actually, the good news in Wisconsin, JP, I learned this yesterday, actually. Wisconsin state employer plans, as of yesterday, voted 2-9 against implementing the accumulator maximizer program that was being promoted by the PBM that they've hired. That's great news in Wisconsin. I hope we've answered all your questions. I want to thank my colleagues, Dr. Ann Sydor, Esteban Rivera, who's my fellow economist, and especially JP Summers, who's not only our patient advocate communications person, but more importantly, she's the patient. She's the person who's being impacted by these things. Please visit our website. The tool's open. Our intention is to keep this going until every state has passed legislation. So we've updated it this year. We plan on updating it next year and the year after, and until every state is protecting their constituents. And hopefully we have federal law to protect everyone. That is under a federal law plan. This webinar was recorded. It will be available to anyone who's interested post. I want to thank Ben Blanc, our manager for program and special projects, Amy Finkelstein, who's our operations administrator, and a very big thanks to Veronica Rodriguez, who's the manager of digital marketing, and put up with my incessant requests about posting and everything else, and emails and all these things for the last 2 weeks. So thank you everyone for joining us. I hope we've answered all your questions. If we haven't, please contact us. You know how to get a hold of us. In fact, if you go to our website, there's an email. You can go directly. Actually, it's my email, so you can send it to me and we can address that. We're eager to help you out, eager to be part of the solution. And at GHLF, we always put the patient first. Thank you very much.